ago, but became very popular because traditionally it's assumed that bacterial strains resistant for penicillins and for cephalosporins are not resistant for carbapenems. Unfortunately, today this position is already changed because the wide use of these antibiotics within last 10 days reduced the sensitivity for them. And in some cases and in some regions, the resistance for carbapenems becomes closer to 10%. So this is already a very high level of resistance. Anyway, carbapenems are still assumed as one of recent drug classes, and on this picture you can see main representatives of carbapenems classes: imipenem, meropenem, ertapenem, and doripenem. In some sources of literature, you can find the division of these classes into first generation and second generation. Is assumed that ertapenem belongs to third generation, when another drugs such as imipenem, meropenem, and doripenem belong to second generation. Ertapenem, as a representative of first generation of these drugs, has broad spectrum action related with bactericidal action. Imipenem, meropenem, and doripenem are also broad spectrum antibiotics. This spectrum covers the most of representatives. Of course, they cannot act on MRSA or some another very resistant kinds of bacteria, such as vancomycin resistant enterococci, but usually these drugs are very, very effective. So you can ask me, what is the difference between generation number 1, ertapenem, and generation number 2, another carbapenems? Main difference is the influence on pseudomonal infection. So first generation and ertapenem doesn't have any action against pseudomonas. Yes, it is written on this picture. While the disadvantage of carbapenems is an absence of oral forms. Yes, so we can use them only parenterally. Second generation drugs such as imipenem are broad spectrum antibiotics with a possibility of influence on both gram positive, gram negative flora, including pseudomonas, but they also have some features. What are these features? A well-known representative of second generation is imipenem, but imipenem actually is inactivated in kidneys. It is inactivated in kidneys by kidney enzyme, and actually that is why we use imipenem in combination with cilastatin. Cilastatin is a molecule which inhibits kidney enzyme, destroying imipenem. And in clinical practice, DNAM contains both imipenem and cilastatin. Another representatives of second generation, such as meropenem, doripenem, are actually not inactivated in kidneys. Yes, they have a better safety profile, and they are widely used in contemporary medicine today. By the way, for imipenem and for ertapenem in some clinical trials was shown the possibility of so-called preconvulsive activity. So they increase the risk of proconvulsive action. Yes, the use of meropenem is related with the absence of this preconvulsive activity. This is also advantage of these representatives of carbapenems. So let's conclude. Carbapenems are used in cases when penicillins and cephalosporins are ineffective, or bacteria already have resistance for these classes of antibiotics. Carbapenems are used only parenterally. Yes, and the choice of carbapenems depends on the possibility of pseudomonal infection presence. If this possibility is low, it's better to use first generation ertapenem. If possibility is high, it's better to use second generation. Next drug class is class of monobactams. Monobactams are also antibiotics with bactericidal action. This is also beta-lactam antibiotic, and classical representative is aztreonam. So the place of aztreonam in contemporary medicine is very specific. Yes, it is effective against the most of gram-negative representatives, and it is usually used for the treatment of gram-negative flora. Yes, the limitation of this drug use is the absence of gram-positive coccal flora action. And obviously, monobactam as another representatives of these subclasses doesn't have any action on methicillin-resistant Staphylococcus aureus, on MRSA. Yes, so the main indication for this representative is a case of gram-negative flora resistant for classical penicillins or cephalosporins. So we've finished our conversation about drugs with beta-lactam ring, and right now we can discuss classes which have a particularly bacteriostatic action. And of course, we should start with golden standard in bacteriostatic drugs. This is a class of macrolides. Macrolides are beta-lactone antibiotics. So their mechanism of action is inhibition of ribosomes and inhibition of protein synthesis, which we already described as bacteriostatic action. Actually, macrolides can be classified in accordance to the length of lactone ring into 14, 15, and 16 membered ring macrolides. Yes, 14 membered macrolides are erythromycin, clarithromycin, and roxithromycin. 15 membered macrolides, the well known is azithromycin. Among 16 membered macrolides, we have jozamycin, spiramycin, and another representatives. So let's conclude that the length of lactone ring makes the choice of these antibiotics some specific. And the most important position of this choice is the absence of resistance for example, 16 membered macrolides in comparison with 14 and 15. So, what does it mean in real practice? If in real practice a person is resistant for clarithromycin or azithromycin, you can use jozamycin or spiramycin, which has 16 membered ring macrolides. They have slightly another point of action in bacterial cell, so it makes their use effective even in cases of resistance for 14 and 15 membered macrolides. The spectrum of macrolides action is officially assumed as wide, as broad spectrum. But you should know that actually this spectrum is more gram-positive than gram-negative. Just look at that. Gram-positive bacteria, obviously, but gram-negative bacteria are covered only with exclusion of Enterobacteriaceae family. Let's translate. The most of gram-negative infections in humans' organism are related with Enterobacteriaceae. So for practice doctors, it means that usually we use macrolides to treat gram-positive but not gram-negative infection. But main advantage of macrolides use is their possibility to diffuse into human cells, which makes, as we already discussed, possible to use them in presence of intracellular parasites, intracellular pathogens. We already called them as atypical infections. Yes, so if your patient has infection related, for example, with Legionella, Mycoplasma, Chlamydia, Ureaplasma, your choice should be started with macrolides. This is their golden place, and any clinical guidelines for antibacterial treatment recommend to use macrolides as drugs of choice in patients with intracellular parasites with atypical infections. So let's conclude: gram-positive spectrum of action and action on atypical flora. the use of macrolides has some advantages and disadvantages. In comparison with classical bactericidal antibiotics, I mean beta-lactam antibiotics, of course, the frequency of side effects is higher. And sometimes macrolide can cause GIT disorders. They can cause another side effects related with the hepatotoxicity, for example. But usually they are also tolerated good. This is an exclusion from the rule when bacteriostatic antibiotics has serious toxic side effects. And to prove this idea, I should say that some of macrolides are even possible to use in pregnancy, when usually bacteriostatic antibiotics are not recommended. Yes, what of them? Actually, two representatives of macrolides are recommended to be used in pregnancy by international guidelines and World Health Organization. These representatives from 14 membered macrolides are actually is erythromycin, from 16 membered jozamycin. So if you have a deal with pregnant lady and she has, for example, a typical infection, which makes the use of bactericidal antibiotics impossible, your choice should be on macrolides, and you can use either erythromycin or jozamycin in accordance to the resistance. Next drug class. This is also a drug class with a bacteriostatic mechanism of action. This is a class of tetracyclines. Tetracyclines are drugs acting on subunits on ribosomes. So in therapeutic concentration, they are classical bacteriostatic antibiotics with both advantages and disadvantages of bacteriostatics. So in comparison with bactericidal, they are not very well in tolerance, but they have advantages of bacteriostatic antibiotics. So actually they can affect atypical flora as well as macrolides. Officially, tetracyclines, in accordance to this picture, are classified into natural and semi-synthetic. Yes, natural tetracyclines are tetracycline, oxytetracycline, and chlortetracycline. The well-known is tetracycline from this group, of course. The initial drug from this class. While semi-synthetic tetracyclines are represented by doxycycline, rolitetracycline, morphocycline, and another representatives. Well known among all of these semi-synthetic tetracyclines, of course, is doxycycline. And in real practice, the most frequent case is the use of doxycycline, and in your own practice, you will work with this drug more frequently than with another ones. Doxycycline has some specifics of pharmacokinetics. It is more lipophilic than first generation. It means better concentrations in tissues than first generation. That is why doxycycline is more popular than first generation. It has good bioavailability, so it means you can use it orally in pills. Yes, this drug has both pathways of elimination, I mean kidney and GIT tract. So you can use it in both patients with kidney disorders and GIT disorders. Yes, so usually we use this drug to treat atypical infections or in case of resistance for another antibacterial drugs classes. But we need to conclude that the use of tetracyclines and the use of doxycycline particularly is not recommended in pregnancy. Yes, because actually the use of bacteriostatic antibiotics with some exclusions, we already discussed them, is not recommended in pregnancy. Next drug class, and also very important drug class, which is widely used in contemporary medicine, is class of aminoglycosides. Initially, aminoglycosides were invented to treat gram-negative but not gram-positive infections. They are still widely used, but with some limitations. These limitations are related with their mechanism of action. We need to know that officially aminoglycosides belong to bacteriostatic antibiotics. They inhibit subunits of ribosomes, they block cellular growth, they block protein synthesis, which means classical bacteriostatic action. But specifics of this action of aminoglycosides is present too. First specific, actually aminoglycosides are ineffective against atypical flora. So we already discussed that the use of bacteriostatic antibiotics is very good in patients with atypical infections. But this is an exclusion from this rule. Unfortunately, in therapeutic concentrations, in routine practice, the use of aminoglycosides doesn't give us significant influence on atypical representatives, and thus the use of these drugs in atypical representatives is not recommended. Yes, we should use macrolides, we should use tetracyclines and other drugs. Later we will discuss them, but aminoglycosides are not drugs of choice. Second specifics and second feature of these drugs. In therapeutic concentrations, aminoglycosides can not only limit the growth and reproduction, they also can kill bacterial cells. So in some of your books, you can find that aminoglycosides are assumed as bactericidal antibiotics. But if you read this literature book carefully, anyway, you will find that mechanism of action is related with bacteriostatic action, yes, influence on ribosomes and protein synthesis. So, today, aminoglycosides are traditionally divided into 5 generations. As usual, the generations have different pharmacokinetic and pharmacodynamics features. So generation number 1, this generation includes streptomycin, neomycin, kanamycin, monomycin. Today, these drugs are very rare in daily practice. And maybe students who discuss tuberculosis on their classes thoroughly already noticed that these drugs are actually used to treat tuberculosis infection. And frankly speaking, this is the place of first generation today. So you will never find them in daily practice. They are used only for this infection. The reason of this indication is their toxicity. So it is impossible to use them daily due to serious nephrotoxic and hepatotoxic action. Hematotoxic action. So in daily practice, their use is limited. Aminoglycosides starting with first generation and aminoglycosides from second generation have an influence on gram-negative flora. So in daily practice for the treatment of gram-negative infection, we usually use second generation, such as cizamycin, tobramycin, and gentamicin. Yes, the use of these drugs gives additional advantages because some of these representatives can kill Staphylococcus aureus. But please pay attention, Staphylococcus aureus, which is methicillin sensitive, but not resistant. So MRSA cannot be affected by second generation of aminoglycosides. And actually, aminoglycosides are usually not used to treat MRSA infection. Yes, this is a place to use another drug classes. So let's conclude. Main indication for second generation of aminoglycosides use is gram-negative flora. Generation number 3, amikacin and nitylmycin are already broad-spectrum antibiotics. So they are used in the treatment of both gram-positive and gram-negative infections. And more important, these drugs have some pharmacodynamic features and some advantages. So we can use them when a person has resistance for second generation of aminoglycosides. Generation number 4 drug is isipamycin, and generation number 5 drug is plazomicin. Generation number 4 and 5 are drugs of reserve. They are broad spectrum, but they are used only in case of severe infections, and in daily practice they are never used. So in real practice, we usually use second generation and generation number 3. So as we already discussed, all of these drugs have a broad spectrum of action starting with generation number 3, but this spectrum doesn't cover MRSA, yes? So it is not rational to make an attempt to treat this MRSA infection using aminoglycosides. In real practice today, in real practice today, we need to discuss two drugs, nitylmycin and amikacin, because they have some differences. As I've told you, both of these drugs belong to generation number 3. But if you make a comparison, you will find that actually nitylmycin is usually tolerated better, but the efficacy in comparison with amikacin is on the side of amikacin. So let's conclude. If you need to be safer in your treatment, your choice from third generation should be on the side of nitylmycin. If you need to be more effective, yes, maybe it is a time to administer amikacin. What should we know about latest generation of these drugs, such as azithromycin and plazomicin, of course? Today, these drugs are invented to treat gram-negative and gram-positive infections resistant to other aminoglycosides. Yes, so as I've told you, these are drugs of reserve. Sometimes these drugs are used in pneumonia, and today these drugs, for example, are included into clinical guidelines for coronavirus-related pneumonia, but in the most severe bacterial complications. Sometimes aminoglycosides, let's take a look, are used in UTI, in urinary tract infections. But we need to know that even latest generations of aminoglycosides, absolutely the same as initial generations, have nephrotoxic effect. So I would never recommend to start my treatment with and your treatment of urinary tract infections with aminoglycosides. European and international guidelines for the treatment of urinary tract infections recommend to use aminoglycosides only in cases of severe course of disease, and only in cases of resistance for initial therapy. So usually these drugs are used as combination with main drug class in complicated patients and in cases of resistance for another drug classes. And in routine practice, it's not recommended to use them. Next drug class, and this class is also very popular today, and this drug class is also included into clinical guidelines for respiratory tract infections, urinary tract infections, in patients with coronavirus infection complicated by bacterial flora, is a class of quinolones. Officially, quinolones are called as bactericidal antibiotics. Yes, are called as bactericidal antibiotics, but you should know that actually their influence is related with the influence on DNA material. They inhibit DNA hydrolase and topoisomerase 4. In translation, they act on reproduction of DNA molecule, which means both bacteriostatic and bactericidal action in therapeutic concentration. So if you wish, quinolones have double action. It gives us both advantages and disadvantages. Main advantage is that presence of bacteriostatic mechanism of action allows to use them in atypical infections. It means in intracellular pathogens, intracellular parasites. Yes, so quinolones are possible to use in Legionella pneumonia related infection, in chlamydia related infection, mycoplasma, ureaplasma, etc., etc. So this is significant advantage of quinolones. Disadvantages are also obvious. So these disadvantages are also related with bacteriostatic action. For example, sometimes in high concentrations, quinolones have nephrotoxic effect, hepatotoxic effect, fetotoxic effect, and chondrotoxic effect, which is specific for quinolones. Yes, so in daily practice, it's not recommended to use quinolones in childhood. In most of countries, they are not allowed to be used in older than 14 years old age. In some countries and in most of European countries, it's not recommended to use quinolones if a person is less than 18 years old. So this is also limitation for quinolones use. In these age groups, quinolones use is possible only if potential benefit from their use outweigh potential risks for for children. Today, quinolones are classified into actually 4 generations. First generation is a generation of so-called non-fluorinated quinolones. So they are not fluoroquinolones, they are just usual quinolones. These representatives are oxalinic, nalidixic, and pipimidic acid. Today, the place of these drugs is not clinically significant. The absence of fluorum atom in the molecular structure of these quinolones makes their efficacy very low. And today, these drugs already have serious level of resistance. So today, non-fluorinated quinolones are used only as additional treatment when maintenance treatment is already finished. Yes, and you need to improve the result of treatment. But initiation of treatment with the use of these drugs is not recommended by contemporary clinical guidelines. So what generations are more perspective to use? Generation number 2, so-called standard fluoroquinolones such as norfloxacin, ofloxacin, pefloxacin, ciprofloxacin. This generation is still very popular. And second generation of fluoroquinolones already has broad spectrum. Yes, the spectrum is more gram-negative than gram-positive, and usually we prefer them to use in gram-negative infections. But do not forget main advantage of fluoroquinolones use. This advantage is an influence on gram-negative infections, but also an influence on atypical fluora. So today, main places of fluoroquinolones are the use in cases of gram-negative infections and in atypical infections. Generation number 3 contains levofloxacin and sparfloxacin. Generation number 4 includes moxifloxacin and gemifloxacin. Both generation number 3, levofloxacin and sparfloxacin, and generation number 4, moxifloxacin and hemifloxacin, are so-called systemic fluoroquinolones. Systemic fluoroquinolones. The term systemic means they have very good bioavailability and they have very good distribution into any tissue or organ. So this is their main advantage in comparison with second generation with standard fluoroquinolones. So they can be used for any infection in our organism in any location. This was main disadvantage of second generation. They have poor pharmacokinetics, poor bioavailability. So if you want to treat local infections, you can use second generation fluoroquinolone. Yes, for example, you can use ciprofloxacin in eye drops. You can use them as ear drops. You can use them as skin cream in topical forms. If you need to treat GIT infection, you can take them in pills, but they will stay in GIT. If you want to receive systemic action, yes, to treat distant organs such as kidneys, such as lungs, for example, yes, it's better to administer systemic fluoroquinolones, generation number 3 or generation number 4. By the way, another name of these generations is anti-pneumococcal or respiratory fluoroquinolones. So if you find in the literature these terms, respiratory fluoroquinolones, anti-pneumococcal fluoroquinolones, systemic fluoroquinolones, you can assume these are generations number 3 and 4. These are broad spectrum drugs and they are very widely used due to this advantage, very good bioavailability and very good distribution in every organ in our organism. So let's conclude. Fluoroquinolones of last generations are broad spectrum antibiotics. Look at this. They are acting on both gram-positive and gram-negative representatives. And they also have an action on atypical parasites. We can use them. Against MRSA, as usual, they are ineffective. Yes, we already discussed MRSA is affected from main drug classes. It is affected only by 5th generation of cephalosporins. So in some clinical trials was declared that the use of moxifloxacin can be related with influence on MRSA. But in real practice, I would never recommend to use moxifloxacin for the treatment MRSA infection. Yes, because for this MRSA infection, we actually invented special drug classes. Before the conversation about these drug classes, we need to discuss some couple of words about MRSA infection. As I've told you, MRSA infection is resistant for almost everything from one side. From another side, MRSA is unusual infection. Usually it has a place in severe courses of disease. Usually it has a place in patients with septical conditions. For example, in cardiology, MRSA infection is frequent in patients with infectious endocarditis, which is also actually a septical condition, usually. Yes, in these cases, we traditionally try to start with usual drug classes such as penicillins, cephalosporins, carbapenems. We can try to combine them with aminoglycosides or macrolides or fluoroquinolones, but as I've told you, usually these attempts are ineffective. So that is why, especially for MRSA, we have invented additional drugs and additional drug classes. Among previously discussed drugs, only cephalosporins of 5th generation have an action on MRSA. What else can be used to treat MRSA, you can ask me. So the traditional drug class which was invented to treat MRSA is a class of glycopeptides. And well-known drug from this class is vancomycin. Vancomycin is traditionally used for gram-positive microorganisms, but actually main advantage of this drug used today is influence on MRSA. That is why usually doctors administer MRSA, administer vancomycin in patients with suspected presence of MRSA infection. How to suspect this infection? This is very simple. If initial treatment fails and your patient has septical condition, you don't need to be a genius to predict the possibility of MRSA infection. Yes, this can be the reason of resistance. And the use of vancomycin in this case can solve the problem. Frankly speaking, vancomycin is a very old drug. And today, sometimes it's very difficult to find it on pharmaceutical market. So you should check your local pharmaceutical market for the presence of this vancomycin, because in some countries it is already not present on pharmaceutical market. What is present and what another drug classes can be used to treat this infection, I mean MRSA infection? More contemporary drug classes, class oxazolidinones. Traditionally, this class is represented by linezolid, and it is present in all of your countries. You can check your local pharmaceutical market. Linezolid today has two main indications. Gram-positive microorganisms. So in case when these strains are resistant to penicillins, cephalosporins, and another representatives of traditional drugs. But second indication for linezolid use is, again, it is MRSA, yes, methicillin-resistant Staphylococcus aureus. So today, linezolid is used as a replacement for vancomycin when vancomycin is either absent on pharmaceutical market or it is present, but an attempt to treat MRSA with vancomycin doesn't give any result. Yes, so linezolid is alternative drug for vancomycin. What else do we receive? Do we have for MRSA infection within last years? 10 years ago, pharmaceutical market has received new drug class, cyclic lipopeptides and daptomycin. Daptomycin, in all of your countries, it is known as cubicin. This is trade name of daptomycin, is also broad-spectrum antibiotic, but the main action of this drug is action on MRSA. Yes, so the use of daptomycin is recommended in cases when another drugs traditionally used for MRSA, such as vancomycin, such as linezolid, are ineffective, and the use of daptomycin can solve the problem. Another new drug, and also very important drug, which is used even for patients with multi-resistant strains, not only of MRSA, but another beta-lactamase producing bacteria, is a class of glycylcyclines. And glycylcyclines today are represented by tigecycline. Tigecycline. So trade name of this drug is Tigacyl. International non-patented name is tigecycline. Yes. So the place of this drug is MRSA infection or another resistant infections related with gram-positive, usually flora. So, colleagues, let's conclude the position of MRSA infection treatment. Your choice can be, let's conclude, fifth generation of cephalosporins. Yes. It can be vancomycin. It can be linezolid. It can be daptomycin, and it can be tigecycline. So you should check your local pharmaceutical market for presence of these drugs, and if you suspect the presence of MRSA infection, your choice should be based on that. And to finalize our conversation about antibacterial drugs, we need to discuss nitramidazole derivatives. Nitramidazole derivatives today are actually divided into two generations. We need to know these are not antibiotics. What does it mean, not antibiotics? They are antibacterial drugs, but they are not antibiotics. Because the term antibiotic means this drug, in the history of this drug, was synthesized by flora, such as penicillins by Penicillium, erythromycin was synthesized by Erythromyces, etc., etc. So nitramidazole derivatives initially were synthetic drugs, yes, and never were classical antibiotics, but they are widely used in daily practice. Their place is very significant, for example, in gynecology, in urology, yes, in venerology. So that is why we need to discuss them. Generation number one, metronidazole, is metronidazole. Two main representatives of second generation are tinidazole and ornidazole. What is the spectrum of these drugs' action? At first, they are usually used for the treatment of traditional infection, but they have a very specific place. They have an action on protozoal infections. So protozoal infections are already not bacterial infections. Yes, bacteria are prokaryotes, protozoa are eukaryotes. So in cases when you suspect the presence of protozoal infections, and usually these are urinary tract infections, yeah, you should take a look at nitramidazole derivatives and to administer one of them. That is why, for example, in gynecology, in dermatovenerology, it's very popular to combine drugs with classical action. I mean, main representatives such as macrolides, tetracyclines, together with nitramidazole derivatives to make the coverage larger. Yes, to receive broad spectrum of action, which includes not only bacterial world, but protozoal infections too. So, colleagues, we almost finished our lecture. Let's conclude the main positions of this material. The choice of antibacterial drugs depends on two features. First feature, this feature is a mechanism of action. It can be bactericidal with its advantages and bacteriostatic with both advantages and disadvantages. Second choice should be in accordance to the spectrum of action. And the spectrum directly depends on generation of individual drugs. How to work with all of that in daily practice? So you can ask me, okay, sir, you have explained us everything, you explained us positions of these antibacterial drugs classes, so how to make the choice in individual diseases? Today, this is actually not very difficult because we have clinical guidelines. Yes, clinical guidelines explain how to make the choice of drug. For example, you receive a patient with pneumonia. You need to open clinical guidelines for pneumonia treatment. These guidelines are present everywhere in internet. You are welcome on your local Ministry of Public Health sites. Everywhere you can find these guidelines. These guidelines usually explain which certain flora is usual for this infection. If this infection has some specifics in accordance to age groups, gender groups, risk groups, you will find a table which makes the difference between these groups. And for every group will be written usual flora. So you already can predict what antibiotics to use. In some cases, we can use gram-positive acting drugs. In other cases, gram-negative. And more important, usually clinical guidelines contain actually names of drugs classes and drugs classes generations, yes, which can be used in individual cases. So you can choose this generation of drugs and you can use these drug classes to make your choice optimal. Of course, sometimes you can make a mistake. Yes, what mistake can happen? Actually, you can administer the treatment, but it is ineffective because this bacterial strain has secondary resistance. Yes, this resistance is a mutation. So it was never present before, but this certain strain of bacteria already has the resistance. Okay, in this case, you can change your treatment. Yes, and this change of this treatment can be in accordance to results of microbiological investigation. So that is why before the administration of antibacterial drug, especially in severe patients, is highly recommended to collect the material for microbiological investigation. This material will be usually ready 7 days after the initiation of therapy. Yes, and actually this is a time of efficacy assessment. So within these 5-7 days, if your initial treatment is ineffective, you can change your treatment in accordance to already received results of antibacterial resistance test. If your treatment is initially effective, you can just continue your treatment actually to receive clinically significant results. Okay, I think this is enough for today for our lecture. So my main message for you, colleagues, is to afraid of excessive antibiotics use. To not administer broad spectrum antibiotics without significant indications. To not administer reserve drugs without very serious indications. To use optimal duration of treatment and optimal doses of treatment. It will not only save your patient from side effects individually, it will save the humanity in the future from the resistance. Please never forget about that. So I think this is enough. Thank you very much for your attention. If you have any questions, I can answer. Do you have any questions?
No, doctor.
No questions. Leticia as usually answers. No, doctor. Thank you, Leticia. Thank you very much. See you in real life. Have a nice day and goodbye. Our lecture is finished.
Goodbye.
Thank you, sir.
Goodbye.
Thank you, sir.